Alright, class. In this lecture, we're going to cover the spine, abdomen, and thorax. Just a few key points about this topic. So, our first slide talks about organ referral patterns. So, you'll need to know these things when you're dealing with someone who's just been hit, like there's a direct blow to the abdomen or thorax, or they've landed on their abdomen and someone else has fallen on top of them. So for the liver, there will be referred pain to the right shoulder blade region, and for the spleen, you'll see pain in the left deltoid region. And um, along with these referral pains, you're also one of the first things you're going to look at is contusion to the abdomen. So you have to think, okay, there could be a fracture to a rib. There can be other internal bleeding, but just some things to think about as well while you're assessing a patient is going to be these referred pains. One of the other ones is for the appendix. Anytime there's irritation or a rupture of the appendix, you'll see pain at McBurney's point, which is about a third of the way from the ASIS to the umbilicus. So if you drew a straight line from the ASIS to the umbilicus, a third of the way there, and you push down on it, that's where you'd feel McBurney's point, or that's where that region is. And the stomach, if there's any injury to the stomach, there will be referred pain to the chest near the xiphoid process. And as far as the kidneys goes, there would be referred pain to the same side on the low back. Alright, our next slide talks about intervertebral discs. So these discs allow movement between the vertebrae, and the typical movement for the vertebrae along the cervical, thoracic, and lumbar spine are flexion, extension, side flexion, and rotation. And discs are the disc in between the vertebrae are very useful for shock absorption. They help increase range of motion and lubrication of the spine. As we move, from cervical, thoracic to lumbar, there's going to be different anatomical landmarks, and we'll talk about some of those when we get to each portion of that spine. One of the things to note is the second bullet point there. It says the disc will migrate away from the direction of movement. So when the spine flexes, the disc migrates posteriorly. And the same, and that you have to kind of remember when you're dealing with injuries, because if someone is complaining of pain or discomfort with a certain direction, so every time they have to bend over, that's when they feel the pain. And when they extend, they don't feel the pain. Then as you're starting to progress them through therapeutic exercises, then you have to take that into account. And you typically are going to start with the opposite direction of their pain. So if it's flexion that's causing pain, then most of your exercises are going to be an extension. Another point to note here are that it says due to the fiber alignment of the annulus fibrosus, so basically the thick ring around the intervertebral disc, it says the fibers are put on tension with rotation. And we can note that a lot of the mechanisms of injuries to intervertebral discs are going to be in rotation. A lot of back problems are caused by rotating motions. And later on, when we talk about disc protrusions, that's one of the things to think about is the mechanism of injury. That is typically going to be a form of rotation, maybe by itself or in combination with flexion and extension. Next thing we're going to look at is lumbar spine mechanisms, lumbar spine mechanics. Like it says there, the vertebrae of the lumbar spine are the largest due to the amount of weight that they have to bear. All the forces, all the weight is typically put on the lumbar spine, so they have to be that big to withstand all those forces. The second bullet point says a neutral spine can withstand 10 times the forces it would out of a neutral position. So that's a really important point, because anytime you are in slight flexion, rotation, extension, your spine is at a more compromised position, meaning it's a lot easier to sustain an injury in that position. And as we'll see later on in the lecture, that one of the purposes of doing your rehabilitation exercises, or preventative exercises for the spine, is to try to maintain that neutral spine even when you're doing a lot of dynamic movements, like in such as throwing a baseball, batting, kicking a ball, jumping, landing. All of those things all start with trying to maintain neutral spine in order to prevent an injury. It says there's several muscles that act on the pelvis and lumbar spine, which can affect the alignment. So here are just some examples of the typical things that you see, or that you will see in your patients when you're evaluating them. For example, tight hip flexors and or weak abdominals will lead to an anterior pelvic tilt, which places the spine in extension. So you could just imagine the pelvis, and I think I mentioned this, or I'm sorry, I might have talked about this before, but anytime you have a pelvic tilt, so if your pelvis is rotated forward, it's going to create a more dramatic lordotic curve in the lumbar spine, so it'll look more like you're in extension. Tight gluteals are going to, and weak paraspinals will lead to increased posterior pelvic tilt, placing the spine in flexion. So that's just the opposite. And it says these alignments may predispose patients to injuries such as spondylolisthesis or disc pathologies, which we'll get to shortly. In our next slide, we talk about thoracic spine mechanics. And here we have one of the most stable portions of the spine, because there's very little movement in this portion of the spine. So we're talking about T1 through T12. Primarily flexes and extends, but there is a slight amount of rotation. And anytime two vertebrae or multiple levels of the thoracic spine are stuck, or let's say the muscles around them are very spasmed, limiting range of motion, you can, most likely, if it's the upper portions of the thoracic spine, it's going to also affect cervical motion. So rotating your head or side flexing is going to be affected. So every time you think about, okay, having low back pain or you're having neck pain, a lot of times the thoracic spine is not usually brought up, and sometimes it could be a part of the problem. The first 10 thoracic ribs, first thoracic vertebrae have articular facets on each transverse process, which means that's where the ribs articulate. And each rib articulates with the bottom portion, or the bottom half of the top rib, or of the top transverse process, and then the top portion of the upper half of the bottom transverse process. So anytime there's a subluxed or a dislocated rib, or a rib out of place, it's actually affecting two levels of the thoracic spine. Like it says here, the upper ribs move in the vertical motion, the middle ribs move in an anterior to posterior motion, the lower ribs move in a medial to lateral motion. And the ribs have to move in order for you to have full range of motion of the spine. So you can't rotate, you can't flex and extend if the ribs are stuck in a certain position. And that's why, it feels very uncomfortable when there is a rib out of place. And typically when it's a facet joint problem, So if it's a problem with the rib and the facet joint, then the patient will typically feel discomfort or pain if you ask them to put their chin to their chest, or if you have asked them to breathe in very deeply. That's when they'll feel a lot of discomfort. And just a few things to note about the cervical spine. It says the difference between the cervical spine and any other part of the body is that you have the ability to kill your patient, according to Maitland, which is one of the doctors that created the joint mobilization techniques. And so for athletic trainers and for someone just getting into the sports medicine field, the cervical spine, anytime you're dealing with that, you definitely want to caution, or err on the side of caution, especially when you're dealing with acute injuries and situations where there may be an emergency. You just want to make sure that you're stabilizing the neck, and call for 911, because you don't want to just think it's a neck sprain or it's just a contusion, when it could be a fractured, dislocated vertebrae. Like it says here, it says no disc exists between the occiput and C1, and between C1 and C2. Just some other names to note is that C1, so the first vertebrae that you see that connects to the occiput, is also known as the atlas, and C2 is also known as the axis. Just some terms that you should be aware of. It says C2 is the first palpable spinous process, because C1 does not have a spinous process. Another thing to note is that the difference between C6 and 7 is that when you flex the spine, so if you touch your chin to your chest, you're going to be able to see C6 and C7. They poke out a lot through your neck. But then when you extend the neck, only C7 will remain visible. The next thing we'll cover is scoliosis. And a lot of you may have seen this before, or maybe you have been diagnosed with a certain severity of this. It could be very mild, or it could be severe. But according to most studies on scoliosis, there's usually major or minor compensatory curves, and the compensatory curves are there to try to correct or balance out the musculature, or the amount of weight you have on one side compared to the other. And if, for example, in this picture here, the patient's head and neck, they're lined up with the pelvis or the hips, and that's because she has enough compensatory curves to correct where her weight is balanced. Patients that don't have totally compensated curves, then their head and shoulders will all lean to one side. So if it's a muscular imbalance that's causing the scoliosis, then typically therapeutic exercise and different types of modalities can be used to try to correct that, and to try to strengthen the muscles that are weak, and to try to relax the muscles that are overworking. Kinesiotape is a modality that's been used and has had a lot of success with this. Okay, so I want to skip over to this slide here, where we talk about the three different types of spondy types of injuries. Make sure that you know the difference between all of these. And there's different severities of this, but here it explains the difference between them. So pars interarticularis is this portion here, so that's what kind of determines what type of injury you have. And to finish up, we just cover stenosis and also different types of disc protrusions that you can have. With the different types of disc protrusions, you can have a prolapse, extrusion, and sequestration, which just determines the severity. And here we just talk about the way you're supposed to do the exercises, like I mentioned before. And that is it for this lecture.